Now I'm honored to introduce Dr. Bola Fathallah. He is going to present from Comfusion to Clarity Mystery case.
I'm honored to present this case in front of all of you. الحالة اللي عندنا النهارده from confusion to clarity. حالة اسمها مايكل. الحالة كانت 7 شهور. CS second sibling of non-consanguineous marriage. كان في history of NICU admission for 5 days out of respiratory distress, during which the echo was done revealing ASD and mild pulmonary hypertension. The echo repeated at the age of 40 days, revealing normal study. The case was leading a normal life, nutritional, developmental, and vaccinated according to Egyptian schedule. Then, before admission, with 3 days, started to have symptoms like cough and rhinorrhea, not responding to medical treatment, presented to the ER of a private hospital with RD2. Not responding to ER management, so the case was admitted on nasal oxygen in this private hospital, which was converted to mechanical vent 12 hours after admission out of repeated attacks of apnea. And hence the first thing that came to mind in this hospital, it's the case was a CNS infection. CT was done, was normal, and LD was done, all within normal values. The case continued in this hospital for 10 days. And then developed respiratory symptoms like coarse crepitation and fine crepitation, and ETA was withdrawn by fire revealed and respiratory syncytial virus. Then the case was referred to our hospital out of financial problems. The condition of the case on admission to our pediatric ICU was CNS. The case was active, conscious and alert with normal tone and reflexes, bugle round regularly active, cardiovascular was normal, chest was on mechanical vent flow setting with bilateral equal air entry and coarse and fine crepitation all over the chest. Chest X-ray revealed bronchopneumonia. And GIT, the case was MBO in 100% IV fluid with Danamin G2 grams. After admission, labs revealed pneumonia, mostly ventilator-acquired pneumonia, which resolved with proper chest care and the proper antibiotic according to culture and sensitivity, and improved in the form of symptoms and radiological improvements. Then the case was planned for extubation, which failed 3 times out of bradycardia, CO2 retention, and repeated attacks of apnea. الوضع اللي كان بيحصل في الحاله كل مره تقريبا الحاله كانت بتتصل من الميكانيكال فنت، كانت بتبقى سموث اكستيوبيشن بصوره جميله. بعدها بشويه الحاله بتبتدي الاي بي جي افتر الاكستيوبيشن 1 to 2 hours الدنيا زي الفل. ثاني يوم السي او 2 90 100 and over 100. Then the condition, the case reventilated out of the apnea and the bradycardia. So the neurological consultation was done, which ordered an MRI. The MRI showed glutaric aciduria type 1. Then we made an extended metabolic screening, which was normal, urinary organic acid, which was normal, and we consulted one of the staff of the neurometabolic and nutrition, which set a nutritional plan for the case and said that we have to respect the result of the MRI we have done. After 10 days of the nutritional consultation and the plan for the case didn't improve, and also it enters in repeated attacks of apnea. Hence was the decision to transfer the case to a university hospital to continue the investigation of the case. The case was transferred to Akurish Cairo University Hospital of Children. And then the condition on admission at Aborish. CNS, the case was hypoactive but normal tone and reflexes, unconscious, cardiovascular normal, chest bilateral equal air entry with no adventitious found. GIT, the case was on full right feeding with no IV fluid. Patient was put on non-invasive ventilation since admission to the pediatric ICU of Cairo University and monitored according to vitals and labs of the case, which revealed repeated attacks of apnea and CO2 retention after sleep. But while awake, the patient can withstand non-invasive and even room air. The labs and ABG of the case was normal. Then full evaluation of the case was done from the start, revealing the MRI, which revealed glutaric aciduria type 2, not type 1, and then a neurometabolic and the nutritional consultation consulted that we fixed to the nutritional plan, which was started at Manchete Bakri Pediatric ICU. And then we have to exclude other causes of apnea. We have done an EEG, which was normal, echocardiography, which was normal, ECG normal, EMG of the case was normal, thyroid profile normal, and sepsis screening with stool cultures from the patient was normal, and sleep study revealed a mild obstructive apnea of the case. So we had done an ENT consultation and a flexible bronchoscope of the case, first to maintain an airways of the patient, which was clear, then a flexible laryngoscope of the patient, which revealed a mild stenosis of the nostril of the patient, and said to us that we have to clear all the upper airways and remove the rhine, and to monitor the patient during sleep with a patent airway totally from the nostrils, the trachea, and see whether she is going to enter an apnea attacks or not. This was done for 3 nights. During every night, the patient was entered in repeated attacks of apnea, resolved only by returning the patient to non-invasive ventilator. So the decision was taken that the appropriate diagnosis of this patient was central hypoventilation syndrome, and we are going to discharge the patient on home BiPAP. The obstacle to this patient was the proper choice of the BiPAP to the patient, which will sense the process of the patient, and the proper choice of the face mask to the patient, which will not leak air from the patient. So we have tried over this patient a lot of devices. Still we reach the exact appropriate device and face mask to the patient, which will sense the process of the patient. Okay. Then the family of the patient or the caregivers of the patient was trained to deal with the patient, and the patient was sent home. But before sending the patient home, we decided to have a full exome sequence of the patient, and waited to the result of the full exome sequence, which revealed that the patient has a FOX2B gene defect, which is responsible for the central hypoventilation syndrome, which is responsible for the apnea attack for the patient. The patient was sent home. She is now, she caught Ross. She is now around 10 months. She can even walk. She is leading a normal lifestyle. And the neurometabolic consultation, the second one after the result of the WEES was done, and they said we returned the patient to normal nutritional plan with no restriction, and the patient now is very good. Okay, this case resembles a harmony between different healthcare facilities, including secondary in the form of our pediatric ICU and tertiary in the form of Cairo University Children Hospital, and harmony between different subspecialties of pediatric medicine, like pediatric ICU team, like genetics, like neurology, like neurometabolic, like nutritional, like cardiology, like ENT, like pulmonology. All of the pediatric ICU subspecialties work on harmony to علشان نخرج العيان بالصوره دي. تاني حاجه بس حابب اشكر الجزء بتاع الانجينيرنج البايو انجينيرنج، ان من غير الاجهزه بتاعه البايبات العينه دي كانت هيتحكم عليها ان هي قاعده طول عمرها على جهاز تنفس في الرعايه. ثالث حاجه حابب اشكرها، ويمكن هو كان عامل لنا مايك مير كلنا اهل الحاله نفسها، لان الاب كان متفكر ان هو بيسال على ايفري ديتيلز، بس بابا الحاله دي كان يعني اور بيجر سبورت في الرعايه. كان مدعم لينا بصوره كبيره في التدوير على الاجهزه، فاهم كل حاجه دلوقتي في الجهاز، وعارف يشغل الجهاز من الالف للياء، بيعرف يتابع ايه في العيان. وحابب اشكركم كلكم ان انتم